This PowerPoint presentation will be addressing the issue of pain management during labor. So why do people have pain when they're in labor? Well, several different things are going on. The tissue has periods where it's ischemic, especially during a contraction. The cervix is dilating and effacing, so there's actual tissue changes. There's a lot of pressure on the soft tissues within the pelvic structure. The fetus is pushing on all those structures, and if the fetus is in an abnormal position, that will make the pain worse. Perhaps the pelvic structure is not ideal, and that is contributing to the pain experience. Also, if labor has been going on for a long time, the woman may be very fatigued and not able to cope as well. As nurses and physicians, we do things to our patients, medical interventions, vag exams, internal monitoring, and all those things factor into their pain experience. Also, there are psychological factors that are going on. There may be social dynamics within the family. Maybe the woman has had a bad experience with a previous delivery or with a pain experience in the past. Maybe she's fearful. Maybe she doesn't have any information about the labor process, and all that contributes to her fear and anxiety and increases her pain. So, what's the goal of pain management? Well, obviously, we want to decrease the pain. In some situations, we may be able to completely erase it. But at the same time, we want to increase or at least maintain the uterine blood flow, make sure that the contractions don't space out or that they don't get less intense. We want to help the woman to relax and not to be tensed up. And we want their fear and anxiety to either go away or to be better controlled. So you probably know from first semester all about the gate control theory. You experience pain somewhere, in this case, the uterus. There is a sensory neurons pick up the pain. They carry it via the spinal cord up to the brain. The brain sends the message back to that part of the body that you're in pain. So the goal is to help to try and diminish or stop that message going to the brain that says, hey, you're in pain. So obviously there are physical conditions during labor that are causing the pain. But at the same time, women are usually very anxious before they go into labor, especially first-time mothers, and their bodies are very tense. They're focusing on the pain, or perhaps they don't have enough distractions and they're bored. And overall, they feel a lot of stress coupled with the physical pain. So what sort of things can close the gate? Well, obviously, there's medication. There's counterstimulation like heat, massage, direct pressure on the back. There are ways to help provide for an environment that's very relaxing and restful, to encourage the woman to have positive emotions, tell her what a good job she's doing. And as the nurse and as a support person, you can work on distracting her or helping her to focus on something else besides her contractions. Before she gets to the hospital, there might be other things that she can do in the home, like watching TV, cooking, cleaning, going for a walk, talking on the phone, other things that could distract her. So what types of things can you do besides medication? Well, there's breathing, there's distraction, helping the woman to relax. When you're trying to help someone to relax, it's really good for you to look at them and assess what parts of their body are tensed up. Usually you see it in the shoulders, in the neck, and in the face, especially the forehead area. Some women might also grab someone's hand very tightly or a side rail very tightly. So what you're going to do is just very gently tell them to, okay, relax your forehead, relax your shoulders in a very calming, soothing way. Cutaneous stimulation, just gentle massaging of the back, or effleurage, where you or the patient could rub the abdomen, providing a sense of distraction. Maybe you want to use some type of mental stimulation, something that they have to concentrate on. So in some of the breathing techniques, you can have them to count. You could have them follow a specific pattern. You could use visualization, trying to create them being in a different place, different things to help them in a non-pharmacological way. Be sure to watch the videos on Blackboard that discuss and so if a woman doesn't want to have an epidural right away or doesn't want to have an epidural at all, one alternative is to give IV push medication. Nubain is a very common narcotic that's given. It's usually given IV push to help a woman feel less of the effects of the uterine contractions. It's usually given for severe pain, so a woman would probably be complaining of a pain level of about 7. Ideally, it's best to give this once the person has started the second phase of labor and once the contractions are in a very regular pattern. But sometimes we do give it in the first phase of labor. The dosage is 10 to 20 milligrams. We give that IV push over about 3 minutes. You want to give that during a contraction when there is the least amount of blood flow going to the fetus. Okay. One of the biggest side effects is the effect on the fetus and also on the newborn if she delivers too soon. And we'll be talking about that in just a second. Okay, because the transfer of the Nubain is very rapid and somewhat variable depending on, how many contractions she's having, you have to really always be worried about the fetus and the newborn. The main side effect that you're going to see in the fetus is bradycardia and decreased variability. So those will probably decrease very shortly after you administer the IV push medication. And for a while, you are going to just watch that. All right. But then if it lasts too long, you are going to intervene. If the woman is given the Nubain and then delivers within a short period of time, then the baby can be born with some respiratory depression. Again, bradycardia, apnea, cyanosis, hypotonia, and decreased APGARs. So you have to be concerned about giving Nubain when a woman is in labor, and then you have to be concerned about the baby after the delivery. So during labor, you are going to have that baby on continuous monitoring, and you will most likely see a decrease in variability. And this is pretty common because the Nubain depresses the neurologic system, not only of the mother, but of the fetus. And you're going to let that go on for a little time, but after about an hour, you might be a little concerned about, if something else is going on there. So you're going to perform fetal scalp stimulation, which is to insert your fingers into the vagina and to stimulate the fetal head. What should happen when you do that is you wake up the baby, that bothers the baby, and it causes an acceleration. This can also be accomplished with acoustic vibration to the abdomen. After delivery, you're concerned because the baby may still be depressed. And you might ask yourself, well, how close to the time of delivery should I be concerned if she received NuBane? And if it's been within a half hour, for sure, I would be concerned about that. Realizing that the peak of NuBane is probably about a half hour, and of NuBane is the half-life of NuBane is about 5 hours. So when this baby's born, you're going to stimulate the baby to breathe just like you would a normal newborn, but the baby might need a little oxygen. And if the baby is not breathing or breathing very slowly, you would have to bag the baby and take the vital signs continuously or probably every couple of minutes.